do whatever your specialty, what are you good at? And what population are you going to serve? And be hyper focused on that discipline, on that service array, what we would call, and then network out. You have pediatricians on one end of the continuum that are more like activists, and then you have sociopaths on the other end that are plastic surgeons. Willy Wonka level paranoia. Consumer, when they have an issue with brain or spine, they want to go to a neurosurgical hospital. They want to see those specialists, and that's what they want to know that's being done there all day long. There's only 6,100 hospitals in the United States, and we take one moron, fire them, and then we just shift them down to the other hospital right down the road.
All right, welcome to this week's Doctor's Lounge. We have a special guest here all the way from cold New Orleans, hot and sunny and sticky New Orleans. Heath Velleman. Am I saying it right, Heath?
Absolutely, that's right.
All right, Heath is here to join us along with Sanat Dixit and Anish Koka, who has figured out his IT problems and is able to log on. So welcome, gentlemen. It's a pleasure to have you all. Anyway, Heath, thanks for joining us today. I have been a huge fan of your tweets, a huge fan of what you're doing down in New Orleans, and not just because I did my training in New Orleans and have a lot of love in my heart for that city. But give us a little bit of your background. Tell us what you do, how you got to where you are, and what kind of challenges you're facing, and why your social media and X content is just so darn good.
Yeah, well, I started as a hospital administrator when I was 20. I left undergrad, went directly to a rural hospital, and started as director of clinics on day one, and was tasked with opening some clinics in the periphery of a hospital. And it just went downhill from there. It's been nonstop. I was going to grad school on the East Coast back and forth during that time. And one day, the president of the Hospital Association stopped by and said, look, if you do not leave this rural hospital, you're going to be pegged the rural guy. And that's kind of how healthcare does work in the administration sectors. You've got the rural people, and in the rurals, there's even subsets like the critical access people and the PPS people. And then you kind of got the policy people that think they've done something and have never really done anything. And then, all these different subsets, the children's people and the academic people and the community hospitals, and they all kind of circle in this. And so I left, and my CEO that had just left the hospital, one of the assets to working for her was that she was on the board of the Hospital Association and the Rural Hospital Coalition and the American Hospital Association. And so I got to be there the whole time. And I knew all these people all across the country and said, I'll open a consulting firm. I was talking to the governor's health policy advisor, and he was like, oh, that's a great idea. He was really the person, him and the president of the Hospital Association. And I left the hospital with one client, and it was a rough 2 years to get it going. And then I kind of stopped working for providers and started working for large multinational corporations, and really enjoyed that. And then in March of 2020, I was sitting in a hotel room and got a call from a law firm, and I was just bewildered about everything that was going on with COVID. It just, nothing was making any kind of sense. I felt like whenever I would talk to a health system client, it was like I had four heads. I was not an epidemiologist, but I had about 12 hours of graduate level epidemiology. And it was just, the science wasn't sciencing. It just wasn't making any sense. And people who I thought were rational had just become highly irrational. And so I was sitting in these hotel rooms, and I got this call from a law firm that said the state is trying to shut down a physician-owned hospital, and got caught up to speed really, really quickly on physician-owned hospital issues. And I knew of some of the issues because I had worked to create them 4 physician hospitals with the American Hospital Association and some health systems, but I had
I think
no
I
idea.
remember that from one of your
Yeah,
tweets. You kind of had a mea culpa tweet saying you had seen behind the scenes, and now you've like seen the light and come forward. So,
yeah.
and you appear to be on the side now of physician owned hospitals. Am I right?
Yeah, absolutely. I mean, it only makes sense. And the reason I refer to myself as a healthcare mercenary, a large kind of corporation once said, you seem to be very agnostic about these matters that we were talking about at the time. And I was like, look, if the check clears, I'll do whatever you want. And so, sitting in that hotel room, though, it became painfully obvious that we the patient was left out of the mix, and the only way to help the patient was to help physicians. And people like me were screwing it up, and had screwed it up so bad. And to this day, I wonder if we can, unscrew the situation.
Tell us what you're doing now, and how do we right this wrong? Again, I see your stuff on X, and you've set up and helped open some physician owned hospitals. So how do we
Yeah.
right this wrong?
And we've got to get the physician and the patient back together and get people like me out of the business of providing care under a different name. So what we should be doing, administrator type people like me, is we should provide a scaffolding and a framework for the physician and the patient to have a healthy relationship. And that's really it. We, ultimately, this goes back to free markets. And we've got to let free markets decide how these things function. I do think we're getting there. The apex of stupidity is payers and health systems. The costs go up, the outcomes go down. And whenever you look at the numbers, we only have so many physicians left in the United States. And there is a whole, just number of factors that's driving these numbers down even further. We've only got about 1.1 million physicians left. About 38% of those are going to age out in the next 60 months. No one wants to go to medical school. I don't know why anyone would want to go to medical school today, rack up $500,000 in debt, come out to work for a health system for the white picket fence and maybe a Mercedes and maybe a dog, a spouse that it's going to be a coin flip of whether you're going to be paying that first spouse out for the rest of your life. I mean, it's very dystopian right now.
Yeah, I think
And
you're
so,
you're you're definitely preaching to the choir. Yeah, I think the med school numbers are people clearly still want to go to med school, but I think that the main issue is when you look at there's some surveys of med students that over half of med students don't actually want to practice medicine; they want to be consultants or things like that. But speaking of free market principles, I mean you're in the right place here. It's not Anish. What are your thoughts?
I think the physician-owned hospital thing is probably for me if I was going to find one thing that I think we could sell to every physician, pretty much regardless of their political stripe, it's the concept of we probably should have an ownership stake in the hospital. We're so fragmented. There's like 1.1 million of us, and we're each lobbying for different things. I think that's a pretty uniform thing for us to get around. The question is, what exactly are we getting around? Are we getting around a concept? Are we getting around an action plan? And then the question becomes, okay, how do you coalesce? I think the business model makes sense, but if you do it a certain way, but I'm really, really interested in seeing how we can go from where we've been pre-ACA to what that vision looks like if they flip the switch and said, you guys can own hospitals again, besides specialty hospitals. How do we get Anish, myself, a bunch of different specialties together to build an acute care facility and start serving the community? I'd love some takes on that.
yeah, it's a great question. Like, there's not ever going to be a physician-owned hospital, and I tell community hospitals all the time not to freak out about this. The physician-owned hospital does not supplant a general acute care hospital. It does not. That is not the utility of a physician-owned hospital. And, but it does serve a distinct purpose for centers of excellence. And the other thing I talk to physicians in hospitals about, I'll get physicians that want to be kind of these community tertiary care hospitals, and those do serve purposes, but they're rare. They're kind of unicorns. Do whatever your specialty. What are you good at, and what population are you going to serve, and be hyper focused on that discipline, on that service array, what we would call, and then network out. The problem that I have with physicians, working for physicians, by the way, can be maddening. And I'm not a physician, but working with physicians can be, oh my God, I used to have hair. But the threat to physicians is not external. The threat to physicians is internal. And for some odd reason, physicians have, and I think it's the training. I've told people for years, I think it's the education and the way physicians are trained, but they do not work collaboratively. And you kind of have a spectrum. You have pediatricians on one end of the continuum that are more like activists. And then you have sociopaths on the other end that are plastic surgeons. Willy Wonka level paranoia. They don't.
I'm surprised you didn't say neurosurgeons there. We usually
neurosurgeons are much more reasonable. Neurosurgeons are smart orthopedic surgeons, and so reasonable. They can work in groups.
If only Chloe was here to hear that.
Cranial orthopedics.
Yeah. Plastic surgeons believe that they are neurosurgeons who drive Aston Martins. They are divas, man, and they are hard to deal with. But if you notice, plastic surgery, they do not work in groups. They are very much these sigmas that are just out there, kind of lone wolfing it, super, super paranoid. And again, you go to the other end of the continuum, and that is this kind of weird kindergarten / activist group of people who only work in these mega groups and who are not super entrepreneurial. Now, I say that with a lot of love for all of them, but you have to kind of know what each specialty brings, the assets and the liabilities, and how they kind of work hand in glove. It would be very, very difficult to have a physician-owned children's hospital. Just because of the nature of the discipline, it would be very difficult. It's also difficult to cross milieu. So, for example, to have a spine hospital, just open one of those 3 years ago, and have pediatrics in that, and have it to be spine and pediatrics. Those milieus crossing are rough. It can be done, and you segregate floor plans and those kind of things, but ultimately, you would have some production issues as well, where the specialty producing certain service lines and certain revenue would feel like they're floating non-producers. And so you have to have real equitable relationships in that. And so there's all these kind of considerations when you're doing physician-owned hospitals. They need to be aligned with what you do every day. You need to have a group of people, a cohort that you trust, that everybody kind of understands the assets and the liabilities and how it floats. So down the road, there's not this murder-suicide that often can happen in physician-led enterprises because there's not this understanding up front of what you're doing, what you're focused on, those kind of things.
There goes my dream of opening a physician-owned hospital with my wife. We were going to do it, babies and brains. That's apparently never going to happen. I agree. That's probably a bad idea.
Well, and I think the consumer wants something that's hyper-focused. And this isn't anything new. Warren Buffett, there is a Buffett rule that he talks about being hyper-focused, being, having this discipline to not be diversified. He talks about these kinds of things. And, he has a little touch of the tism. And Charlie Munger really drove that kind of home as well, that you want to be really hyper-focused. We can apply that to healthcare as well. And so that's what the consumer wants. The consumer, when they have an issue with brain or spine, they want to go to a neurosurgical hospital. They want to see those specialists, and that's what they want to know that's being done there all day long. Similarly, if it's a child or an adolescent, they want to go to a children's hospital. They want to be in an environment where this work is done all day long. It's not, of course you all know that.
Yeah, that makes perfect sense. And I think that's part of the issue. We kind of talk a little bit on this about some of the things that go on in organized medicine and in training. And I think part of the problem is that most trainees in medicine work at large multi-specialty, quaternary care hospitals. And so they don't even realize that the specialty care hospitals exist and can be very good and can be very excellent at, doing spine surgery as a one-stop subspecialized enterprise. You need maybe a hospitalist to manage some of the perioperative, diabetes and whatnot, but you don't need cardiothoracic surgery there. You certainly, don't need OB. So I think that totally makes sense. And that's the whole, going back to Adam Smith and specialization, right? That's how we get more efficiency and productivity.
That's exactly right. Become hyper efficient.
Do you worry, Heath, about not really solving the larger problem? Like, is it possible that we make things worse in aggregate? Meaning, once you have a specialty hospital set up, the advantage and the good thing from a societal standpoint is that you can probably get higher quality, higher efficiency, more patient serving, more, you're aligned better with patients, and all of that is at much lower cost than what these large hospital systems are doing. But do you end up potentially making things worse in the long run by incentivizing, medical care, because you still haven't dealt with the fundamental problem here, which is we don't have a free market. We have a third-party payment system. So if you now just have a bunch of specialty hospitals dotting the landscape that are able to access this, third-party payment model, do you end up with a lot of care that perhaps isn't needed, or because you're not dealing with the fundamental issue here? So is there, so I wonder sometimes if there's a way to do this that's feasible when you're not eliminating the third party payment matrix that we have.
Well, I think ultimately the third party will go away. And I know that sounds bizarre and, impossible, but, Jeff Bezos talks about life cycles of business, and everything has a life cycle, everything. And I think where we are today is at the end of the life cycle. And if, to take a more ontological view of this, these kind of 40-year loops, whether you subscribe to the Howe generational theory, or, solar cycles, or, whatever these kinds of things are, there's definitely life cycles. And I think we're at the end of a life cycle right now in healthcare. And I think over the next 60 months, you're going to see a big realignment. And I think it starts with physicians saying, you know what, I've had enough of this, and there's got to be a different way. I hear exactly what you're saying. In kind of what we would in grad school, it's not real ethereal. Fragmentation, which is really what you're driving at, has cost, and fragmentation creates duplication, and that does drive costs in the system. And a good example of that, and again, I'm not picking on them. I've opened over 2,000 clinics across the United States. But let's take rural health clinics throughout the U.S. I think Louisiana, we're now up to 300 rural health clinics. Why do you need a rural health clinic across the street from a rural health clinic? That makes no sense whatsoever. Now, our only alternative to that is to do some central planning, which I do not support, and have certificates of need and those kind of things. The idea, the reason that we have all these rural health clinics that have sprung off, though, is because the incentive, again, is this encounter rate. that is higher. So like if I'm a pediatrician in Baton Rouge, I get $47 for a 99213. But if I'm a rural health clinic in Zachary, I get $163 for a 99213. Same care. So it drives the incentive that's dysfunctional in nature is driving that fragmentation, driving the duplication, and our costs go up. That could happen in the short term, I think, with specialty hospitals. But I think in the long term, what happens is if physicians will come together, that is the hard part of this. And the external issue of third-party payers and direct contracting is really not the problem. It's how do physicians come together and leverage what they have to get to direct care. So, for example, if I'm all the physicians in the U.S., now that's magical, and we all come together and we have a network of specialty hospitals. We have a network of clinics, of IDTFs, of all of these services. And we allow businesses, we direct contract with these businesses in their states and in their region, and we network out. That works. Now, I don't believe that top down will work in this. I think it has to start bottom out. I think you have to bottom up. You think you have to start in your community, go directly to the payer. And again, the Baton Rouge hospitals come up a couple of times. Just take the Baton Rouge area. Baton Rouge has a spine hospital. They have an orthopedic hospital. They now have a breast cancer hospital. If those three hospitals would come together and say, oh, let's approach Dow Chemical and say, we can do this service array for you. And we can reduce your costs by, without even looking at one number, I know I can reduce their costs by 10% because that's what the TPA is making on their healthcare. So I can go in and say, right off, I don't even need to look at your data. I can reduce your costs by 10% right now today. And that's a big driver for some of these companies.
So I think that makes total sense. And I was going to ask how the kind of direct contracting works. But on that note, I think a part of what Anish is getting at is so much is a third party government payer where you can't, you can't go to Medicaid as much and say, we're going to offer you a better deal. Right. And so when you have like these rural hospitals that are 60, 70% Medicaid, how do you take the free market into effect when your only option is to be a government contractor, right? And so you have to deal with these rules. Is there a way to do that without drastically scaling back? And I know this is things that we discuss kind of ad nauseum here, scaling back the government payers and putting those people back into, private market. But is that possible under the current, Medicaid landscape?
Well, if we use the current landscape today, it's suboptimal, meaning we would have to go through a waiver process. But for example, if we were to use a CBDG, like a community development block grant out of the Medicaid budget in the state, you could take parts of the risk, carve it out, pool it, and do it just like direct contracting. And you could use the CBDG model for that. There's some, we've done that some in ACOs. There's a reason I don't like ACOs, and I'm not talking about any physician-owned ACO or anything like that. But ACOs perennially don't work because health systems aren't payers, and they're already bad at being health systems. Why would I want the goober running the health system to now have an ACO? That's why they don't work. They don't understand risk to begin with. They don't understand pricing. If I go to a physician-owned hospital, the physician can tell me how much a sponge costs. If I was to go to a particular health system, I won't use the name of a particular CEO, and ask how much a sponge, they couldn't tell me. They would say, call Vizient, or call HPG, or call Premier, or call the vice president of supply chain. They're so dislocated from capital that it doesn't work. However, we can gain real efficiencies if we were to carve out those risks in the Medicaid program. And you can do it. It doesn't have to be done by whole cloth. You can do it in demonstration pods to show that it works state by state. And all the risk doesn't have to be the same. But we do have evidence that it works. There are, as the ACO model has gotten refined a little bit more, a little bit more, a little bit more, it is still way too high cost. But even in those models, we can demonstrate value over time by doing that carved out risk. So in the current framework, if we didn't touch anything, we would have to use like an 1115A or 1115B waiver, and then do some block grants.
Are there any states that allow waivers in Medicaid for physician-owned hospitals that aren't grandfathered into the Medicare program? And that's maybe that's too nuanced of a policy question, because obviously we want to overturn the POH ban entirely in Medicare, but I know Louisiana has some POHs that are grandfathered in, but just generally will Medicaid's, I guess it's a state by state thing, but have you encountered any Medicaid programs that would provide a waiver for a POH?
It's a great question. It is state by state for sure. I'm working on 3 right now. And that is kind of top down. I'm waiting on some feedback from HHS. HHS, their initial and CMS, their initial opinion of this has been very high, and they are certainly open to thinking outside the box. The problem when you get into state Medicaid and messing with the match is you're messing with supplemental dollars. And I have tried, like, the provider taxes that everybody gets kind of up in arms about. Whenever we were doing criminal justice reform here in Louisiana is a great example of this. I was like, look, to match Medicaid, all you have to do, it just says that it needs to be a public fund. So sheriffs particularly were struggling with paying, and DAs could not pay. They were having to pay out of pocket, and so they were having to gin up new millages. And I was like, all you have to do is match that and send it through LDH and draw down the funds. But no one wanted to give up part of the match because the match is maxed out in every state. There is no room. And so you start eating into people's dollars and they get extremely defensive. And I think POHs are going to run into that as well. So HHS and CMS has really got to think through how the FMAP is structured right now.
Your thoughts on one of the surgeons who's been pretty public on social media in her battle with United Health and peer-to-peer, and apparently she has some type of a surgical center and invested a fair amount of money in it, and because of this battle that she's had with United Health that's been very public, they've dropped her now. So your thoughts on that?
It's like retribution, right, for speaking out against the plans.
I think she's doing what I would do, and that is to shame them in the press. That's the only way you can really get them to do anything. It is direct retribution to the extent she has a claim. I would file it, but those kinds of claims are, they probably start at $250,000 to forward. That could easily be $2 million in legal fees all day long. It is, she's in a very, very difficult position. And I've only followed that peripherally, because the hospital in Baton Rouge, that was a breast cancer hospital, and we had to get a United Health contract. And because this is public, I won't talk about how we got those contracts, but I take a stick and carrot approach. And, if the carrot doesn't work, then there are other ways for me to get to the payer that can be painful for the payer. And that's just from me having worked for payers. So, but, I hate to see what she's going through. That particular discipline that she's in, also, they're probably weighing in on, this is a company that owns one of those centers. United Healthcare owns a breast cancer ambulatory surgery center, and I think they own it in Houston. So they're not just, I think it's a major free trade violation. I think the FTC should look into it. I mean, they're also a competitor of hers in the same state. And so, it is, it's a mess. That's a mess. I hate to see it.
Do you think an approach was that a good initial approach from where you would stand, just strategically? I'm not talking about moral or ethical or whatnot, but I mean, is an approach, if you're recommending folks do this, does it make sense to be so tied into insurance networks? Is it possible to do this and not be an insurance network?
Yeah.
What and then if, depending on what your thoughts are there, say you're tied into insurance networks, what exactly do you do with mountains of denials? Like, what's the best approach, would you say?
It's very market dependent. So if I am in a small market where I know a bunch of the industry and I know that they control, almost 70% of the commercial claims, then I'm going to go pick off the top five largest TPAs and direct them to me. However, when you're talking about like breast cancer, for example, very different than spine, very different than ortho, because it's such a small population. So if I've got 30,000 employees, I'm probably only going to be throwing somewhere in the neighborhood of 300-ish breast cancers. So, it comes down to some math about, how do you take them out? So in cases like that, sometimes my approach is to sidle up to the payer, to go to the payer and say, how can we do a hybrid provider payer model? What's your liabilities running here? And so I go talk to a mid-executive, some vice president of network or vice president of payer relations, somewhere there, get some insight into what their liability is and see if we can collaboratively drive down costs from a tertiary care hospital that's probably eating them alive. And then I say, okay, how do we box out that tertiary care hospital and drive your costs down? So the model, it all depends on the market. This is, by the way, why I do not, work for community hospitals and health systems. They no longer hire me. They do not see me as friendly and say lots of not nice things about me. But that, I now use them as leverage in some of these cases. Their costs are so high, their executives do not understand them, and they certainly don't understand discrete service lines. Even ones where you say this is that it may be an 11 or 12 or 20% margin contribution. The CEO doesn't know where the contribution is really coming from. It's embarrassing just of how poorly these hospitals are run. So you have an advantage if you know your market.
So then why, Heath, why would this happen? Why wouldn't the insurance companies be salivating over a lower cost center to send folks? I mean,
Yes.
you think, it would be in their best interest. So if you have a surgical center that is, if there's a lot of denials accruing, it doesn't make sense for them to deny things to procedures and surgeries that are much more, expensive. If it's the case that these are procedures that are going to happen at some high cost center, then why not sign off on this for a low cost center? So it must be that they actually believe that these are things that do not at all need to be done. Would that be your conclusion?
It could be, but remember, these are human beings after all. And so, I come from a human behavior background, and, people like to be courted and people like to be put on pedestals, and, people do not like to be embarrassed. And I wish I could say that United Healthcare, the executive team, that corporation, United Health Group, has made just a series of horrible mistakes over the past 10 years with its hiring and just, its mission, vision, values is just crazy. It's probably, you could probably fire 15% of that company today and not even feel it. It is so just overbloomed, really poorly managed. And they are all shell shocked. They are hyper sensitive, and so you kind of have to dance around United. They also are just embedded in all kinds of different ways. So these are people who do absolutely retaliate. The markets are much smaller than you think. Healthcare is a very small industry. We're very insular and cloistered. It's a screw up, move up industry. There's only 6,100 hospitals in the United States, and we take one moron fire them, and then we just shift them down to the other hospital right down the road. They're just as stupid at the other hospital. And so, but that's the nature of our industry. We don't hire from without, which is a big deal when I'm talking to physician-owned hospitals. I say, find you somebody who's never worked in healthcare. They're going to look at your problems differently. You're the physician. You're the decision maker. You have somebody that's an administrator. You don't need a CEO. You need an administrator who can help you look at problems differently. So I say all that to say, in my experience, the best way to do this is to sidle up to the payer and show them that you're solving a problem for them, and you're trying to exploit a little bit of their weakness. And then you're going to leverage the health system to do that.
I think it's a lot of the large health systems don't even hire healthcare. They just hire within their own health system.
That's right.
I think I totally agree with you there. There's an interesting article in the Times that just came out that kind of ties into this, how a lot of the rural hospitals are blaming private insurance for their closures, saying that because of their lack of leverage, the payments they're getting from the private plans are the reason that they're having to close. And again, to Anish's point, it seems like the payers would look at that and say, well, we could keep sending patients to this lower cost community option, but if we can't keep that facility afloat, they're going to go, 100 miles away to the quaternary care center where the costs are going to balloon. So maybe it's just a testament that we need more competition in the plan space as well.
I was just going to say, ultimately, direct care is where it needs to head, and get that third party out completely. And I am an idealist, so being an incrementalist is very hard for me. But in this space, it is kind of a bite by bite kind of deal. Unless your market is, unless you're able to pick off some big employers quickly and it supports your disciplines.
So I want to give a little counterpoint, a little bit of a pushback over here. Heath, what you're essentially talking about is building a marketplace, is a parallel marketplace, and appealing to a level of consumerism. The problem is, well, I'll ask the question. Do you think the average person in the United States is an erudite healthcare consumer? And I ask that question from the standpoint of how are they thinking about the payment and consumption of healthcare? Because essentially we have been trained to think of it as an employer-based benefit that we pay monthly for, and we think about co-pays and we think about deductibles. We're getting to the point that the average family of four is spending something in the neighborhood of $24,000, $25,000 per year. So it becomes a pinch that the average person feels. And 15, 20 years ago, the employers were feeling this pinch. So the employers were like, we're going to self-insure, and we're going to go at risk, and we're going to try to manage all this stuff. I think it's going to take a sea change to change people's mindset on this. That's number one. Number two, healthcare has become a leviathan over the past 20 years. Certainly in the past 10 years. I think you guys may have seen the article. It said something like 22 states, a healthcare company or a hospital is like is the largest employer in the state. And like, it's gotten to the point that it's too big to fail because so much money is flowing in. The third point is, I think conceptually, these are great things to try to implement and execute. I was chasing this down about 13 years ago when I went to India, because I looked at physician-owned hospitals over there. I was like, I can own a hospital in India. I can't own a hospital over here. And I saw how people were doing it there. Back then, 80% of people paid out of pocket. Only 20% of people had insurance. And since that time, they're slowly emulating our system. There were good elements of that because you have price transparency and tangible value propositions. And I can go on ad infinitum about a couple of hospitals that I went to. But you got something else with consumerism. You got getting hospital beds turned into eBay. And then when you got in there and you saw a version of Anish, even though he's Indian, just imagine him in India, where they're going to put a stent in, they'd come out and offer the patient's family the option of 3 stents. Cheap, middle price, and drug-eluting, super fancy schmancy that's the most expensive. They say, which one do you want me to use? So it became almost too consumerist. The last point, the absolute last point, even if we could do all these things and we could extricate ourselves from the payers, they have so many levers and how they can come after physicians and physician-owned hospitals. If you have a Medicare patient and they're paying out of pocket and they come to your facility and they think that you self-referred that person to your facility, even though they're paying out of pocket, they could chalk that up as a Stark violation. And when we look at all these things that are arrayed against us, I'm like, it's a great concept. I'd love to see it happen. I'm just concerned. How do we tackle all these individual things to even begin to bring this stuff to fruition? Because there's a lot there.
The first thing I would say is that physician-owned hospitals, they are not, and all hospitals should be like this, but there is no one-size-fits-all. There's not one solution for every single case. These should be very much tailored to the community, to the scope and size of the physicians, and what patients need. Be there for sure. I will say that one of the things that's working for physicians right now is just the state of the consumer in the U.S. The inflation is eating them alive. And so when they get their check, especially W-2 consumers, when W-2 employees get their check, the dollar's just not going as far. The first thing they look at is taxes. The second thing they look at is healthcare. And so they're starting to say, well, what am I getting for $1,500 a month? Am I spending $1,500 a month on healthcare? And then when I go to a hospital, I've still got to come out of pocket 80% on some of these employer-based insurance plans, because the goal of the employer is to shift those costs, just like you said, the employee. So employees today, consumers are looking for a whole variety of options. And, some large retailers that I have worked for in the past, developing some of these solutions, know that. And look at the robust telehealth solutions that are all out there now. Those solutions, by the way, were never for direct care. They were to drive pharmacy. All of these retailers had an interest in pharmacy, and so they were to drive drug, and then they would pair the drug in different sections of the retail stores or the online platform. It was really never about direct care, but it provided some interesting results about what the consumer was willing to spend and what they really wanted. And I'll give you an example of an orthopedic surgeon right now in Cleveland. He has a direct care network. He charges $5,000 a year to be a concierge orthopedic surgeon. And you're looking at a guy who said, that is insane. Why would I pay an orthopedic surgeon who gives me periodic care? His deal is you get, up on the surgery schedule faster, you get appointments quicker, you have my cell phone, all these kinds of things. But when I talk to patients, they're in pain. These patients are in pain. They would do anything to get some of these, to get to the Ivera injection. These are people who were spending somewhere in the neighborhood of $18,000 a year on employer-based health insurance, and it was taking them 4 months to see an orthopedic surgeon. That was in network and that could get PAs. And then when they got the PA, they couldn't get the injection that they needed. That was, that their friend had told them that was really working, and all these kinds of things. And so, I think the consumer is in a very different position today. And I think the stars are kind of aligning, that people are starting to ask questions about, why was I charged $9,800 for a CT? And why do I still have to come out of pocket $1,200? That makes no sense. I think the point of that is just that the stars are aligning to where it's not just the physician who sees we've got to make a substantial change in the way that we do healthcare. The consumer is right there with you. And so I don't think that you're going to be on an island where the consumer, you see, specialty hospitals start to pop up. I do think there could be some fragmentation and duplication issues, but to the extent physicians will work together and collaborate, you'll also drive your costs down. You can scale through network. You don't have to share ownership and all this kind of stuff. But I think the consumers can be right there with you.
Dan Choi is here from Long Island. Long Island's greatest spine surgeon, of course.
Greatest.
Dan, Heath is talking about physician-owned hospitals and how we can change the landscape. Are you going to offer a concierge prepaid benefit plan, or are you going to open up your own hospital, or both?
As a private practice owner-operator of my own practice, what I can tell you is that me and my physicians, soon to be a group of 5 completely independent physicians, no private equity, running a physician-centric practice, that really everything is catered, because at the end of the day, happy doctors, I think, results in great patient care, right? When a doctor can focus on, just treatment algorithms and sitting there and working up patients and making treatment decisions, and then focusing on pre-op planning as a spinal surgeon, looking through the imaging and making sure I'm getting prepared for this complex operation I'm going to do tomorrow, or maybe I'm going to do 3 of them. And everything is kind of designed in my space, outpatient space. So I really don't have to worry about documentation, logistics, worrying if a patient got cardiology clearance or authorization done, because I have designed the infrastructure in my outpatient space so that my throughput, all I'm thinking about is maximizing clinical throughput and also maximizing quality of care for my patients. I just want to focus on what is the best surgery for my patients, how do I plan for that, how do I get to that outcome, and kind of working on that. And I've optimized it. And so my outpatient experience is a very fluid, it's a very efficient and pleasant experience. And when I walk into my outpatient space, my staff understand what my needs are, and really everything is very physician and patient centric, and everyone's been trained to do that. They understand what the ultimate aims and goals of this practice are, physician driven. Like, what's my goal? My goal is to provide the highest quality spinal surgery operations and do the best I can, and all my staff are aligned with that. And if your goal does not align with my goal as a surgeon for my patients, you don't belong in the organization. And so the most painful part of my day as a practicing physician, or a painful part of my week, is stepping foot in a hospital. Now, not all parts. I mean, there are awesome parts about the hospital, like the hospital cafeteria might be amazing, or, they have great coffee machines. And you know what? There are certain incredible staff. Like, I have my OR team at one of the hospitals. I have my X-ray tech that I work with. I love him. I have my certain OR circulating staff that know my preferences, and they're awesome. If you really look at how a hospital works today, it is what I like to say is that they've overreached. Right. So I do these routine microdiscectomies, things that, really there's like 4 trays, and I have my preferences. I have like 50 steps, and they just need to get the 50 steps right. And guess what? A hospital sometimes, because they're trying to handle complex cardiac care on top of orthopedic care, on top of urology, top of ENT, they're doing like 30 different specialties in this hospital, and trying to pull in all these elective cases. You're too big. You don't have the bandwidth to train every single person, every scrub tech on 30 different procedures. The best trained scrub tech can't be prepared for 30 different specialties. Okay. And so this is why when you have certain, I think, even physician run hospitals or ambulatory surgical centers, which are, a lot of these are physician owned, it makes more sense. You're more streamlined. You have a spine specialty hospital, everyone, and I've talked about this, I think, on the podcast here in New York State. There is a for-profit hospital in New Jersey, just across the bridge, that I actually go and take my cases to, because they run, out of 10 ORs that they run, 8 out of 10 of them are spine. Pretty much like 4 to 5 days a week, they just do spine only. And so it's highly specialized. And I literally will take my patients across the bridge to go there, and I'll tell my patients that it's a better experience because everyone is trained to do spine surgery. And so guess what? If I owned my own hospital, I would make that hospital run exactly to my liking, and making sure that Every OR day that I step foot is maximum efficiency and maximum safety and maximum quality for the patients. Yes, it has to be financially viable, but just like my practice, financial viability comes hand in hand with being able to provide safety and quality. If you're not financially sustainable, you can't do these things. But at the end of the day, as a physician taking an oath, safety and quality edges out kind of all other things. And so it would be a patient-centric facility that, and hospitals do the same. I'm not saying hospitals don't do the same. Hospitals have the patient in mind and they're very patient-centric. But I think what would be big is that you take the perspective of the physician who's delivering care and you cater to them and you make sure that they can do everything without any encumbrances or any restrictions, and that their life is made easier. And in turn, the quality of care goes up, the clinical throughput goes up, patient access to care goes up. And this is why I think physician-owned hospitals are the answers. You're having the physician lead the ship and designing the infrastructure so that my day can be just as nice in the hospital as it is in my outpatient space.
Dan, I had asked Heath about earlier about some of the issues with health systems, hospitals running things versus what physician hospitals do. And I'd specifically asked about this whole third-party payment and how that kind of creates issues in what you're talking about in creating the most efficient, friction-free type of model. Part of the issue with running hospitals in today's age is that they're highly, highly regulated, right? Okay, you want payment? Well, hey, you got like JCO, you got all this, crazy amount of regulations and that don't make a lot of sense. Do you think? Do you think that you can have a specialty hospital that is truly efficient and truly physician centric without massive regulatory reform, or of course without third party payment?
I think it's possible. I think that it's such an unexplored territory, right? And I think, look, I wouldn't say I'm like the world's expert on physician-owned hospitals. So I'd like to look at, the physician-owned hospitals that existed prior to the moratorium from the Affordable Care Act. I would look at how they've done things, right? Because studies have shown, I believe, the studies that I've seen, is that the quality of care and the efficiency is, if at least as good, if not better, in physician-owned hospitals than the health systems now. So, I would look at what have they done to survive in this environment of consolidation and third-party payers. And it may not be that you can have this environment, completely free of regulations. Hospitals are complicated places. We know that if things are not run correctly and there's not certain code that's followed in terms of building code, life safety code, that patients can be at risk. So there's got to be some oversight. I think that physician-owned hospitals, I would study what type of, what kind of bylaws, what kind of regulatory guidelines that and they fall under the same ones, I'm sure, under JCO, whatnot. Like, what have they done to make sure that they maintain quality and access and efficiency and still, kind of follow the regulations that they need to follow today.
Yeah, I think a lot of it's going to be based in the state as well, right? The states have varying regulations for running a hospital. I know somebody that has a physician-owned hospital, and there's a state regulation that you have to have a nurse staffing the hospital at all times. They do spine specialty stuff. They don't operate through the weekend, so they pay a nurse to sit there throughout the weekend and staff an empty unit. Because that's the state-based regulation. So a lot of that's going to come down to the state. I think, JCO's not, you don't have to use JCO. It's not mandated that JCO inspect your facility. CMS mandates that you have to have some sort of third-party accreditation, but there are actually competitors to JCO, which I think most people don't realize. JCO's not, it's a private entity, and there are competitors for JCO. Whether or not they're any better, I'm not so sure.
I thought it was particularly interesting to listen to Heath talk about his experience working with different for specialties and how he really highlighted that one of the problems with physician-owned hospitals, at least multi-specialty physician hospitals, is that some specialties are just not going to be compatible with each other. You're not going to be able to have like a spine and pediatric hospital because of the kind of the personality differences, and then also reimbursement is too different and whatnot. So I thought that was super interesting. It makes you wonder whether or not like is the hospitals as they have been set up, is that really the best we can do? Meaning, if you had physician-run hospital, how the heck would you do a physician-run hospital if you had like this huge group of of different specialties and stuff? Like how do people play nice? He seemed to suggest that the problem is not external, the problem really is internal in terms of getting people to work together. And I don't think I can completely disagree. So maybe the best step is these great regional hospitals or specialty hospitals, like I guess Banner and Barrow. Am I getting it wrong? Barrow or
Yeah, Barrow's a great example, especially from a neurosurgery perspective.
Yeah,
and I think that there's certain subspecialties that just by their very nature and how their contract and predictability are more suitable. So we were talking earlier about obstetrical hospitals, obviously orthopedic, spine hospitals. But I'm probably never going to fulfill my dream of a physician-owned trauma hospital, right? That's right. Probably, although I could, yes, I'm not saying it's not happening. So Heath, we were just talking about the different types of hospitals that may be more amenable to physician ownership. And I said, I'm probably not going to be able to have my physician-owned trauma hospital, but, we're wrapping up at the top of the hour. It was great having you on. What are your closing thoughts, Heath? And give us some hope moving forward. How would you, a couple main reforms you would advocate for, and what's some good things on the horizon?
Well, I think the good news is the moratorium is probably going to go away. I think that is going to happen. I think physician-owned hospitals are a great resource. They do work best in certain specialties for sure. Not everyone can be DHR. That is a leprechaun riding a unicorn. Those things are that's very, very rare. But they are, the literature shows they're lower costs, they provide better outcomes, and patients are happier with them. I also just think that we're at the end of a life cycle with a system, and that is the way healthcare is delivered today. There's a life cycle for everything, and Bezos talks about that better than anyone else. I think right now Ray Dalio is hitting that pretty hard. We're seeing the end in healthcare. And so there's a new cycle that's coming on board. And I think if we can get the problem with dislocated capital, and that is the problem with third parties, if we can get that out of the way, and I think the way that happens is just more direct contracting, more direct fee for service provide, however that looks. It can be PMPM, or it can be actual fee for service between the physician and the patient, however that happens. And I do think HHS and CMS are open to that. I think there are going to be massive changes within the next 60 months in healthcare.
That is a positive ending. I think if there's one thing we can all agree on here is that more local control, more private sector control is probably going to be better than more centralized control. So
one last question. I think you brought on some really interesting points, just real quick about dislocated capital and cycles. What signals do you see in the marketplace right now, or from a regulatory or from an advocacy standpoint, that signal to you with some certainty that we are at the end of a cycle? To us who've been fighting this kind of policy battle for the last decade, all I see are big mountaintops that are still ahead of us, right? I see us rolling the boulder up. Sometimes we get a little momentum, and then the boulder comes rolling right down back on us. Medicare fee schedule cuts, United seeming like, they're kind of, on their heels, and then, really they just have one more trick up their sleeve, and enough politicians that they've connected with that are always going to take big insurance's side. So what indicators do you see that feel like you can confidently say that we are at the end of a cycle? And on top of that, if we are at the end of a cycle, what would you need to see from physicians, from politicians to actually start a new cycle that is actually something different from what we're seeing. So these are just like, I guess, like practical questions. Like, I want to be a believer in what you're saying. I love what you're saying, but tell me what you see that would help convince me not to be so pessimistic.
Well, I am a Dio-ite. I'll be the first person to say that. So I look at macro cycles, macro patterns. I'm very plugged into what macro markets look like globally. And that's the first thing. The consumer is your bellwether. And the consumer is tired. It's not just about they can't afford a house. It's they look at their W-2 paycheck and they're looking at the taxes that's taken out, and the next thing they're looking at is healthcare costs. So it's no longer soluble for the consumer, and that's going to mean for the business. So for the business to retain employees, and the business is now connecting, I need healthy employees. My production is dependent on the health of the employee. Communities are starting, at least on a local level, understand that economic development, the cornerstone, is a healthy taxpayer. I can't turn 2.3x dollars in my community if I have people on disability, or if I have people that are non-productive at their house. I need them to be productive. And so we're at a place now that's really driven by the consumer. Second to that, though, is where the physician is at. The physician no longer feels kind of satisfied to get up, go to work, and be controlled. And I think part of this was COVID. COVID was a driver, and I think everybody went along to get along, and finally have had enough and said, you know what? I think it's okay to say that hospital administrators are stupid. I think it's okay. I think we can all admit it. We've all talked about it. We all joked about it. But now we're seeing it's ruining our lives, and it's ruining our patients' lives. And people are getting serious about it. And then they're starting to do math. I think there were people in this country who thought that there were 20 million physicians for 400 million people. And there's not. There's 1.1 million physicians that are licensed in the United States of America. 38% are aging out in the next 60 months. There are no physicians left. If just 10% of physicians said, you know what, I'm no longer going to take governmental payers anymore, Medicare, that is not sustainable for Medicare. That's not sustainable for the government. Physicians have way more leverage than they know. They're just now starting to find that out. And part of it's their education. The appeal to authority is a real thing in human behavior. It has worked against physicians, but they're now kind of breaking out of that matrix, quote unquote. And so I think you see these two parallel tracks, the consumer and the physician, that are, I guess to be a little hyperbolic, breaking out of the matrix, if you will, and starting to say, you know what, this doesn't make sense. It just doesn't make sense at all, and we have to have a new solution. And I would just tell people, it doesn't, the mistake everyone makes in every industry all the time, and we learn this from other industries and other classes of businesses, is to try to go at scale right away. This works bottom up. So it works in your community, with your patient base, at your local hospitals, with a small group of physicians. Where do these discussions need to happen? They need to happen in the physician's lounge, the doctor's lounge. No pun intended. They need to happen in your small groups, and it will spread like wildfire. It's the truth. It's the truth, and watch it spread. The numbers the math is on your side. I'm a big math and physics guy. The math is on your side.
That was great. Fantastic way to wrap this up. Thanks everyone for joining this week. Heath, our guest, has been fantastic. Anish, Dan, Sanat, good seeing you as always. Join us next week for another episode.